Hi, I'm Joe Shovlin from Scranton, Pennsylvania. I practice at Northeastern Eye Institute, and we're part of Vision Innovation Partners. We're a large group of 36 doctors in Northeastern PA. I think some key takeaways on the rare infiltrate lecture, uninvited guests of the cornea, would be that there can be significant diagnostic confusion with a whole array of assorted pathogens that we deal with, especially in contact lens wearers. I'd say easy to confuse bacterial and fungal infiltrates. Probably not so easy to confuse bacterial and acanthamoeba, but acanthamoeba certainly can be misdiagnosed as herpes simplex, because in acanthamoeba there's really a reduced corneal sensation, not an increased corneal sensation or pain, at least initially until they have a scleritis or more morbid infection. I think the other key features of this particular discussion is that there are infiltrates that look in bacterial, for example, they have little spicules in strep infections. The organism releases dextran into the cornea, so you have these filamentous-like infiltrates, which very easily could be confused for fungal infection. And also in Mycobacterium, they have more of a wispy appearance, and also with MRSA and MRSA, you just really get a little bit of different impression from the infiltrate versus conventional staph or strep epi that's methicillin sensitive to that particular organism. The other thing I think is helpful is in acanthamoeba, we have to realize it is a stealthy, very chronic infection, often diagnosed late. And the earlier you diagnose any of these conditions, then that would give you a better prognosis. So anytime in fungal disease there's high pressure, there's a tuberculitis that portends a poor prognosis, and there is a death zone where there is some risk for endophthalmitis. Anytime you're close to 2 millimeters at the limbus, those patients should be grafted. Most cases of infectious keratitis can be managed by any capable optometrist. There are exceptions though when there's rare infection like acanthamoeba and some fungal disease. I think that's probably best managed by a corneal specialist or somebody who's used to seeing those cases on a regular basis. They know what medications to get, and as quickly as they can get them, the better off the patient's going to be. I think it's important to know the stigmata or signal data that would reflect a more severe infection. And anytime there's organic trauma, anytime there's deep suppuration, scleral extension, the patient's in the hospital, it's a nosocomial infection, those patients should be cultured. So you should have that available to you if you plan on diagnosing as well as treating these conditions. I think in any contact lens wear, it's compliance and make sure the patient's adhering to their wearing schedule and make sure they have the right solutions. They don't want to skip or cut corners in any fashion. And I think swimming with lenses is taboo, especially in the summer months when our folks are swimming in our area, or especially after environmental risk or shifts when there's hurricane season. The pools are contaminated. They should probably avoid wearing contact lenses at all times when they're exposed to water. I think a couple things that would be important to close with, and that is that anytime something doesn't respond to seemingly appropriate therapy at 5 days, they probably should either be referred out or you need to rethink the diagnosis, because if, for example, if you think this is a bacterial infection and not getting better in 5 days, you need to think about something else like a fungal infection. If you're treating the patient for herpes simplex and not getting better in a seemingly appropriate period of time, they need to be reevaluated, maybe recultured even, and I think that's important as well in any contact lens wear.